Good morning and welcome. It's my great pleasure to co-chair this morning's session with Professor Clare Gilbert. Today's symposium will be the best paper presentations for the Gerard, Crock and John Parr trophies. The Royal Australian and New Zealand College of Ophthalmologists, members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islanders people of this country, sovereign custodians of country. We acknowledge their continuing presence and the contributions made to the college and the communities we work in. We will respect past elders and communities and will continue to live, work and interact in a respectful manner with present and future elders and communities. The RANZCO Reconciliation Plan reflects the messages of its First Nations engagements. It's a great pleasure to be here this morning. Just some housekeeping, if I may. This is meant to be an interactive session, and we would ask you to submit questions via the app. Many of you will have done this in previous sessions, but essentially you open the app, select this session, and scroll down to the bottom where you'll see a live Q&A question opportunity, and you can type your questions, and Clare and I will be monitoring that throughout the talk. Each with hopefully to inspire some good discussion throughout. So each presentation will be 10 minutes with 3 minutes for questions afterwards. And with that, I'd like to turn it over to Clare to introduce our first speaker.
Good morning, everybody. And first of all, congratulations to the 6 speakers on their abstracts being selected for presentation. So the first speaker is James Pietris, and the title of his talk is Waste Produced by Cataract Surgery, a clearer view on the impact of operating theatres on the world's climate crisis. Thank you, James.
Good morning, everyone. My name's James Pietris. I'm a junior doctor with Queensland Health at the moment, and along with my co-investigators, we conducted a study examining the waste produced by cataract surgery. Healthcare accounts for 7% of Australia's total carbon footprint, which is comparable to the carbon footprint created by South Australia as a whole state alone. Interestingly, this is much more than other large nations, such as China at 1.3% and India at 1.5%. Australian hospitals produce approximately 236 million kilograms of waste annually, and up to 70% of this comes from operating theatres. Of this total, plastics account for about 25%, and despite this, are becoming increasingly adopted worldwide due to their convenience and low cost. So why is all of this important? Not only does it endanger the environment, but also our health. Aggravations in respiratory disease and increased prevalence of vector-borne disease, as we've all experienced extensively over the last couple of years, are significant consequences to be aware of. Our aim is to move towards a healthcare sector that is able to meet the framework set out in the Paris Agreement to limit global warming by 1.5 degrees Celsius by cutting greenhouse gas emissions by 50% by the year 2030. To start off, I thought this was an interesting graphic showing cataract surgery numbers per 1 million people of various regions throughout the last 5 to 10 years, and just emphasises how common cataract surgery is not just in Australia, but worldwide, and both in developed countries and the developing world. Numbers like these only increase the contribution of cataract procedures to global carbon emissions and further emphasise the need for awareness around waste production and management in operating theatres. We conducted a dual centre evaluation of phacoemulsification cataract surgery removal procedures within the Gold Coast Hospital and Health Service in 2021, encompassing both public and private hospitals as part of a larger study that also included analysis of orthopaedic and obstetric procedures. Following collection, waste was segregated into 5 categories: soft plastics, hard plastics, metals and electricals, paper and cardboard, and textiles, which included gowns, drapes and the like. Following primary data collection, estimated carbon emissions were then calculated. This was done using the Australian Government's 2020 Institute of Health and Welfare National Greenhouse Accounts Factors, which are designed to provide nationally accepted conversion factors for estimating carbon emissions per weight unit of different waste categories. As we can see here in Table 45, the AIHW has provided an estimate of the degradable organic carbon expressed as a proportion of each particular waste type, labelled DOC and occupying the middle column here. These DOC values are derived from historical waste data. Conversion factors have been assigned to each waste type in the right-hand column. These conversion factors are mathematically calculated and take into account DOC along with other factors that influence waste breakdown and contribute to emissions, including the methane fraction of landfill gas, which has been designed as a constant value of 0.5, recovered methane across a year, an oxidation factor, which has a default value of 0.1 for covered, well-managed landfills, and a value of 0 for uncovered, poorly managed landfills, and the conversion rate of carbon to methane, which is a constant of 1.336. The resulting conversion factors can be seen in the right-hand column of Table 45. Of note, the category of inert waste, listed to include concrete, metals, plastics, and glass, has been assigned a conversion factor of 0. This value assumes 100% of inert waste is correctly recycled, not contributing to carbon emissions at all. This is a significant limitation of our study that I will touch on a little later. 21 cataract surgery procedures were audited across the Gold Coast Hospital and Health Service, producing a total of 69.15 kilograms of surgical waste, including 14 kilograms of hard plastics, 12 kilograms of soft plastics, 14 kilograms of paper and cardboard, 23 kilograms of textiles, making up the majority of waste at 33.7% of the total, and 4.5 kilograms of electrical waste. Based on an average of 1,655 cataract surgeries performed between May 2020 and April 2021 within the public Gold Coast Hospital and Health Service, total annual waste production was calculated to be 5.45 tonnes. Total annual carbon footprint as a result of these cataract procedures was calculated at 7.52 tonnes of carbon dioxide equivalent. We were able to draw two major conclusions from our study, identifying two issues that we believe are key to curbing the surgical waste production problem. The first of these is the lack of appropriate infrastructure and recognised processes to enable staff to appropriately segregate waste in theatre. In the first instance, this remains a major barrier to appropriate waste disposal in the operating theatre environment. Secondly, the current practices and staff knowledge surrounding waste management in theatre could be improved, and it is apparent that waste management is certainly not at the forefront of minds of theatre staff. While primary concerns should always lie with the patient, we believe improvement to at least a base level of awareness of waste management is definitely achievable. I've listed a few limitations of our study here. As I mentioned earlier, the major one pertains to calculating carbon emissions for each waste stream. The AIHW waste conversion table makes a large assumption for a few of the waste categories, assuming 100% of inert waste, including concrete, metal, plastics and glass, is recycled correctly with an assigned conversion factor of 0. While conducting our study, we found this largely to not be the case in practice and observed countless occasions of disposal of plastics in particular into landfill. This categorisation by the AIHW affects 3 of our 5 waste categories, hard and soft plastics, as well as metals and electricals. And as such, while our results still did show significant waste production from cataract surgery, they are likely a significant underestimation of the true waste burden. I also wanted to touch on the last one of a small sample size. We audited only 21 cataract procedures as we found that we were consistently replicating results to within 0.1 kilograms for each procedure, as typically the same sets of equipment and packs of gowns and drapes would be used. And after 21 surgeries, we were confident that if we added to this number, the results would have largely been the same. We suggest several recommendations to improve waste management in operating theatres. At a management or government level, introducing yearly carbon emissions quotas for individual surgical departments may help to curb the waste production problem, but also will reduce procedure numbers and subsequent benefit to the community, so must be employed only with careful consideration. Workplace-sponsored education and training programs for staff would serve to increase awareness of the issue and change the culture from a grassroots level. And in conjunction with assuring easily accessible waste disposal receptacles, this seems like probably the most practicable initial solution. And in several places in the UK, similar things have been in place for years with good effect. Incentives for staff or departments may also help to drive healthy competition for appropriate waste disposal amongst surgical teams in the hospital. Utilising reusable items that are able to be repeatably sterilised, as has been documented in some less developed overseas countries, albeit likely due to a lack of resources rather than an overt desire to reduce waste production, is also another option. However, the potential difficulty of this with respect to stringent infection control requirements in the sterile environment of theatres is acknowledged. In terms of future research, there are several areas that would benefit from further investigation. James et al. In 2015 conducted a study comparing waste production secondary to trabeculectomy surgery in the United States and compared this to data for the same procedure from India. The Indian hospital produced an average of 0.5 kilograms of waste per surgery, while the American hospital produced an average of 1.4 kilograms of waste per surgery, almost 3 times the Indian hospital. Further comparison of waste produced by cataract surgery across international settings may further inform environmental aspects of future practice. A Malaysian study by Crock et al. In 2019 analysed the amount of waste produced from phacoemulsification cataract surgeries performed by consultant surgeons when compared to trainee surgeons. 0.81 kilograms on average was produced per consultant-led procedure, compared to 1.1 kilograms when the procedure was performed by a trainee. It would be interesting to have data examining this comparison in an Australian setting and in other settings internationally. But ultimately, larger-scale cost-saving analyses are required to further investigate the most effective ways to combat the issue of surgical waste production in operating theatres. Thanks, everybody. Questions?
Thank you, James, for obviously touching upon something that's becoming more important to discuss. Obviously, the next thing to investigate after cataract surgery will be intravitreal injection waste. Is that something on the horizon or has been looked at either in Australia or internationally?
Yeah, definitely. And since this study was performed in 2021, that has definitely become a major topic of interest in the waste production landscape. We did plan future studies to investigate intravitreal injections among other things related to ophthalmology and waste production. However, no further studies have been completed by our investigative group. But in the current literature, there have been several studies that have been noted in the years since completion of this study investigating intravitreal injections significantly contributing to waste production in cataract surgery, in ophthalmology, apologies.
Are there any questions from the audience?
Hi, Samantha from Perth, Western Australia. I might have missed this, but you mentioned differences between trainees and consultants. Any difference between public and private hospitals?
From our results, we actually didn't find any difference between public and private hospitals at all. The results were, as I mentioned, replicated to within 0.1 of a kilogram, regardless of whether they were performed within the Gold Coast Hospital and Health Service or through private hospitals on the Gold Coast. However, I suppose over a larger sample size and over several locations in different states and countries, it would be interesting to see whether there was any variation from public to private.
Thank you.
Robin Geimer from Melbourne. I wondered if there was any comparison with other surgeries from other specialties. Are we particularly bad?
Well, there was, this study was part of a larger investigation examining orthopaedic and obstetric procedures. I think total disc replacement surgeries in orthopaedics and caesarean sections in obstetrics. And both of the orthopaedic and the obstetric procedures, as we can all probably imagine, produced a lot more waste per case. But I guess the major consideration with cataract surgeries is the prevalence and how the large numbers of cataract surgeries performed per year as a whole may add up to more when we consider the case numbers of orthopaedic surgeries and obstetric surgeries and compare them to cataract surgeries.
I have a question. Is there more from the floor? What impact do you think bilateral simultaneous cataract surgery might have on the amount of waste?
Yeah, that's another area that's being investigated quite heavily at the moment. And I suppose some aspects of surgical waste production relate to prepping the patient and things that would only happen on a per case basis in theatres. And I suppose doing bilateral simultaneous cataract removal procedures would eliminate the double up of some of those waste sources, such as drapes, gowns, etc., gloves, and that may help to to definitely reduce waste production by reducing overall case numbers.
Wonderful, thank you. Well, I've just got from the live chat, someone has answered my question, which is intravitreal injection carbon footprinting has been done by people in Wellington in New Zealand and published in our local journal. So there's the answer. Thank you, James. I'd like to invite our next speaker to the podium, Dr. Rasha Altaie, who will be presenting on early detection of keratoconus by artificial intelligence. Thank you, Rasha.
Thank you, Amy. Good morning, everybody. I'd like to talk today about early detection of keratoconus by artificial intelligence. Artificial intelligence is an emerging field in ophthalmic science and medicine, and there are a few terms that you might be familiar with. The first one is the artificial intelligence, which is the ability of the machine to imitate intelligent human behavior. Then we move to the deep learning, which is the application of the AI that allow the machine to learn spontaneously from experience. And then the deep learning, which is the application of the machine learning that depends on complex algorithm with a neural network to train the model. AI is not new. In 1950, Alan Turing proposed to consider the question, does the machine think? That's when he published his paper in Mind in computing therapies and intelligence. This is followed by 1959 by Arthur Samuel, who defined the machine learning that the field of study that allow the computer to learn without being explicitly programmed. He played with the machine checkers until the computer beat him. So the machine learning does not only mimic intelligent human behavior, but it focuses on the hidden pattern to identify and to be more accurate, to identify the accuracy in prediction. Then we move to the deep learning. In the deep learning, it's a type of machine learning that's based on a neural network. So if I show you here that there is an input and an output, and in the middle, there are hidden layers. And that's based on intelligent algorithm and the neural network to differentiate and to get the best out of the data. So if I move here, the difference between the machine learning and the deep learning, the machine learning learns by repetition, while the deep learning, the learning based on input, output, and the hidden layers. So if you look here, you can see that the repetition helps to get the output. Here it is all algorithm and neural network. So we ask the question, can AI be used to detect and differentiate normal and early keratoconic corneas from non-keratoconic corneas with a comparable sensitivity and specificity to a cornea specialist? In Auckland, why this is important? As you are all aware, keratoconus is estimated to occur in 1 in 2,000 people worldwide. In New Zealand, has one of its highest prevalence, which is approximately 1 in 200 adolescents get affected by keratoconus. And the condition disproportionately affects individuals of Maori and Pacific Islanders. It's up to 1 in 45 adolescents of Maori and Pacifica, they may get keratoconus. And furthermore, that the individuals of Maori and Pacific Islanders appears to have the disease to occur at earlier age and more aggressive, and it progresses very quickly. So what we did, a data bank of corneal images has been downloaded from the corneal tomography in Auckland Pentacam. 3,000 New Zealanders' cornea with 12,000 images were edited by 2 cornea specialists, myself and Dr. Jay Meyer. And then the images were divided into normal, keratoconic suspects, and other diseases. Then the AI training split the data into 70, 15, 15. That's for training, validations, and testing. Then the AI software engineer designed the architecture design to choose which one to use to detect keratoconus. So I just want to mention that with the AI designs, there are different designs in the deep learning. The efficient net has 7 bays. They vary in width, depth, and accuracy. And just to highlight here, when it comes to the CNN, which is the conventional network, which is type of the deep learning, as you can see, there are so many of them. And that depends on the number of parameters and the accuracy. In our study, we created 21 million parameters with the 200 layers to reach the results. And as you can see here, the efficient net, it's very accurate. And it's probably superior to too many others architect designs in the CNN. However, I want to mention that in the AI world, more accuracy means more cost. And that's in the computing as well as in the Amazon Web Service cloud. So that's where it becomes difficult to design one of them. Now, our results so far. The algorithm currently achieved 85% accuracy in differentiating between normal and definite keratoconic corneas, and 80% accuracy to differentiate between keratoconic suspect and definite keratoconus. The algorithm achieves this with less than 5 seconds per image. And in September 2021, we start to look prospectively. So we managed to get the Amazon Web Service connected to the Pentacam at the hospital. And we try to get lively the image. We can't do it on daily basis, so we do it in bulks on weekly basis because of cost. And so far, we got 88% accuracy. I had to update the slide this morning because I received the results on weekly basis. Like, this is from last night, 88% accuracy. The AI engineering is working on a complex design to achieve more than 90% of sensitivity and the specificity of the algorithm. And currently, what we are doing, actually training both Medmont and Pentacam at the same, like taking images, from both Medmont and Pentacam to train the AI on both devices. What is the difference? AI to detect keratoconus has been published before, but our studies is trying to take images and to train AI to detect keratoconus from different devices. Compared to what is published in literature, it's all from a single device, and it becomes very confusing to the AI to detect from another device once it's trained on single one. Furthermore, we are trying to correlate the severity of keratoconus with the age and ethnicity, as we think this will be of great benefit to our highest risk group, who are the Maori and the Pacifica. So, the goal is to use AI to identify keratoconus from different devices. And hopefully we could make the technology more affordable to the old optometrists and to use it in the community. And hopefully we start screening kids for keratoconus in New Zealand. Thank you very much.
Thank you very much for your very interesting presentation.
Thank you, Claire.
Do we have any questions? Anybody there? Can't see. I have a question for you.
Certainly.
Do you have data on the specificity and the sensitivity of the testing? By the accuracy, I guess you were saying
yes.
If they were negative, negative, positive, positive.
Yes.
Yeah. So do you have the data on the specificity?
I don't have it at the moment because we keep it as live updating. Sorry, it is live updating, but we are getting high sensitivity and specificity, over 80% in all, to differentiate between the normal and the suspect and the keratoconic ones. But this is, we are aiming to get more than 90% to make it more that's the first goal. And then we're trying to get more images from different devices. Like the aim is to get really a high sensitivity and specificity from affordable corneal topography to be used for screening, which is, we are finding it very difficult.
Thank you.
Yeah.
I'll carry on asking questions. So further down the line, once you've got the final model,
yeah,
I think it'd be very important for you to find out what the positive predictive value is, given
yes.
the low prevalence overall.
Yeah.
Yeah.
Yeah. We are, yes, I'm aware of that, and we are working, but we're just trying to get the AI first. As you can see, it's baby steps to learn how to differentiate. But the more data, he's asking, like the software engineer is looking at millions of images to help to reach that high level.
Sure.
No.
I have another question, sorry to hog it. Wearing my public health hat,
oh gosh.
I'm thinking about when you're actually taking it into schools.
Yeah.
How readily scalable will it be? I mean, what's the cost of the technology, the training implications?
Gosh, you hit a very hot point at the moment. We are looking really first through the ethics to go through schools. We've already identified 3 schools in South Auckland with a high percentage of Maori and Pacifica to scan, and the cost, that's actually, it's all out of a grant from Potter Trust at the moment, but it's I am hoping to enroll it with the school screening. In New Zealand, we have the kids screening, like the vision and hearing at the age of 12, but now we're really looking, I've been looking worldwide for if possible, a handheld can't be very accurate to detect astigmatism and keratoconus, but we need kind of an affordable machine to use, and that could be a big step to make it affordable to be used. I'm not aware, probably Prof. McGee could help me here, if there is any cheap devices that we could use to make it affordable to go for screening. At the moment, it's going to be very hard to use very expensive machines to use it for screening at schools. So next year, by the beginning of the term, we're hoping to get Medmont to be used because it's cheaper than Pentacam, but we probably need as much cheaper device. I'm aware that OcuWell is working on a device, but it is a handheld one, and I don't think it's going to be very accurate, and it is not FDA approved yet.
Okay. And playing devil's advocate, it would be interesting to see how this screening tool compares with a simple visual acuity assessment and refraction.
Yes.
I'm talking about within the context of a school program.
Yes, that will be interesting to see. And the mainly thing we were like, because as you know now, like you could, the 612, sometimes, they get referred, the 612 vision, they get referred for screening. And whether that will be, it will be interesting to correlate that, how many of those they have early keratoconus, which they get missed just by refraction if it is very, very early stage of keratoconus.
Okay, thank you very much.
Thank you.
And the third speaker is Brian Ang, and the title of his presentation is A Randomized Controlled Trial of Cataract Surgery versus Combined Cataract Surgery with Insertion of iStent Inject. Thank you.
Thank you. Good morning. It's a real pleasure to be here this morning presenting the results of our iStent trial at the Eye and Ear Hospital. Before I start, I'd just like to disclose that we received trial funding from Glaucoma Australia. I'd also like to acknowledge the contributions of the entire glaucoma unit for supporting and contributing to this trial. I'd like to start by taking a walk down memory lane. So in 2016, 2017, minimally invasive glaucoma surgery reached the shores of Australia, and it was such a hot topic. This is because before then, we only had 3 surgical ways to reduce IOP: trabeculectomy, glaucoma drainage seton, and cyclodiode laser. However, with the introduction of MIGS, we now had 4 stents that could reduce IOP in the fraction of the time taken to perform a trabeculectomy. And this was the iStent, a transtrabecular device, the ill-fated CyPass, the suprachoroidal device, the Hydrus microstent, and the Zen gel stent, which is a subconjunctival drainage device. We even managed to get a Medicare item number, a new one, 42705, for combined cataract surgery with a transtrabecular stent. So it is with this backdrop that we decided to look at the iStent and how it might benefit an Australian population in a tertiary hospital setting. So we recruited glaucoma suspect and mild to moderate open-angle glaucoma patients who needed cataract surgery. And we randomized them into phaco alone or phaco plus iStent. And the idea was that we would follow these patients up over a period of 2 years. Because we wanted to mimic the real-life clinical setting, we opted against a preoperative washout period. However, the eye drops were stopped after surgery, and these were progressively reintroduced in a stepwise manner depending on the IOP at the follow-up visits. In terms of the surgery, there was no change to the way we perform surgery and the way we would manage these patients post-operatively. Those eyes that were randomized to the iStent, they would have the stent implanted after the IOL was inserted into the bag, and we would look for reflux of blood to make sure that the stent was placed correctly. So the main outcome measures were IOP and number of medications used, and the secondary outcome measures were ocular surface dryness parameters and also quality of life. So with ocular surface dryness, we use the ocular surface disease index score, which is a series of 12 questions, and depending on the answer, which is plotted onto a chart, then it will give a scale of 0 to 100. The higher the score, the worse the dry eye disease. And for quality of life, we use the Glaucoma Activity Limitation Questionnaire, the GAL-9, which has 9 items, and the responses range from 1, which is no difficulty at all, to 5, which is severe difficulty. Our power calculations estimated that we would require 90 eyes per group, so in total, 180 eyes. So we were very excited at starting this trial. However, we rapidly ran into 2 major challenges. And the first challenge was slow patient recruitment. And on the face of it, that didn't really make sense because at the glaucoma unit, we performed a lot of cataract operations on glaucoma patients. However, when we looked more deeply into this, we realized that a lot of patients did not fulfill the inclusion criteria. They were either only eyes, or they had advanced glaucoma, or they had complex glaucoma, or complex ocular comorbidities, or they had previous filtering surgery. And more crucially, those patients who were able to afford it, they would prefer to have their surgery privately because they wanted the guarantee of having the stent in their eye rather than go through the lottery of a random allocation in a trial. And we also faced a next subsequent, even more difficult challenge.
Good evening, Mary Guerin with ABC News. The whole of Greater Melbourne is heading back into lockdown. Just 8 weeks since rules were eased, 5 million people are returning to stage 3 restrictions from midnight tomorrow. The stay-at-home orders will affect all 31 council areas that make up metropolitan Melbourne, as well as Mitchell Shire to the north.
So COVID-19, it was a period of fear, confusion, and lockdowns. Melbourne became the world's most lockdown city, and the lockdown rules seem to be changing on a weekly basis. And and scenes like this were commonplace throughout the streets and roads of Melbourne. And as a result, there were many instances of missed follow-ups and missed reviews. So how did we do despite all this? So we eventually recruited 104 eyes, 54 to the phaco plus iStent group, of which 51 completed 24-month follow-up. 50 eyes were randomized to the phaco alone group, of which 47 completed the 24-month follow-up. So this table shows the baseline characteristics of the two groups. The only significant thing about this table is that it did not show any significant difference between the two groups. Similarly, with the adverse events intraoperatively and postoperatively, there was no significant difference between the two groups. However, there seemed to be a trend towards increased trabeculectomy in the phaco plus iStent group. We did not find any significant differences between the two groups at 4 weeks, 22 weeks, 12 months, or 18 months. However, at 2 years, we found that the eyes in the phaco plus iStent group had less requirement for topical agents, so there was a greater number of reduction in eye drops for the phaco plus iStent group. And when we looked at the proportion of eyes that were medication-free, in the phaco plus iStent group, there were more eyes that were medication-free at the IOP threshold levels of 18 millimeters mercury or less and 15 millimeters mercury or less. So our results found no significant difference between phaco plus versus phaco plus iStent in terms of the visual acuity, visual field, quality of life, and ocular surface disease parameters. We found a significant reduction in the requirement for medications at 2 years in the phaco plus iStent group. And we also found that more eyes were medication-free in the phaco plus iStent group. However, our results have to be interpreted with great caution, and that's because it was underpowered to start with, and this was compounded by the missing follow-up data as a result of COVID-19. Nevertheless, our results seem to compare reasonably well with other studies, recently published Australian studies on the iStent. The comparisons of ocular surface disease index and quality of life is a little bit more difficult because of difficulty finding literature using the same questionnaires at the similar time points after surgery. Our work on this is still in progress. So in conclusion, our trial found that phaco plus iStent was able to reduce the burden of medication at 2 years compared to phaco alone. This was borne out by the fact that there was a reduction in the number of eye drops used and also the proportion of eyes that became medication-free. And finally, while I appreciate this is beyond most people's control, but really try not to do any trials in the midst of a pandemic. Thank you very much for your attention.
Thank you, Brian, for a great talk, although you've given me some serious Melbourne lockdown flashbacks. I'm having post-traumatic stress just up here. Do we have any questions from the audience for Brian?
Amy, it's Robin. Just, Brian, I wonder about the adverse events, given that you had sort of 2 procedures versus 1. We didn't hear about your adverse events.
Yes, let me go back. Sorry, could you please repeat that question?
I was wondering about were there more adverse events when you had the 2 procedures versus the 1? Maybe I missed this.
Sorry, yeah, no, there was no significantly greater adverse events in the phaco plus iStent group compared to the phaco alone group.
Thank you.
Brian, I have a question. Obviously,
yes.
It's compelling to try and get patients off drops, given the issues around compliance that these patients have during their lifetimes. I'm interested in, you mentioned some other studies. Have any studies shown a drift back towards these patients with iStents subsequently requiring to restart their drops with time? Has that been noted now that MIGs have been around for 5 or 6 years?
Yes, I think the clinical experience is that over time, there is going to be a greater need for restarting eye drops again. And I think that if we had extended the iStent trial to longer, we would find that as well. But I'm not sure at what point the phaco plus iStent would reach parity with the phaco alone group. I have no data on that.
And just in terms of this slide here, how is there an explanation, the trend towards needing a trabeculectomy in the group that had the iStent, or is that a statistical aberration, do you think, given the low numbers?
I think it was a statistical aberration in the sense that we were probably getting a little bit desperate in the way we recruited our patients. And so patients that were kind of at the borderline, we would probably shouldn't have recruited them in, but we did. And so that's how we ended up with that.
And I'm interested, I would have thought that the quality of life questionnaire would have actually shown a difference in terms of those patients requiring less drops. Do you have a comment on that?
Absolutely. So I think this is because of our study being significantly underpowered.
Yep.
And also because we had a lot of missing data. So as a result, it just wasn't able to be strong enough and powered enough to give us the required statistics to demonstrate a benefit.
Do you have any other questions from the audience?
Yeah, I've got one question. Could you please indicate whether there was an intraocular pressure difference between the two groups? And is there any possibility of bias in restarting drops or stopping them based on which group they were in? Thanks.
That's a great question. So with regards to the IOP, because we had a sort of target IOP in mind for the patient, so the fact is that IOP is probably not a very good indicator of outcomes. Rather, a more useful measure would be the proportion of eyes that were medication-free at certain IOP levels. That's because the way we designed this trial was that if the patient's pressure was increased, then we would have to add on eye drops to get the pressure to the relevant target pressures.
I've just got one question from the live chat, Brian. The question is from Chelsea Garmer. Did you look at the difference in costs was there a cost-benefit analysis done between the two groups?
That's another great question. I think this has been addressed in previous studies where they found that phaco plus iStent was cost beneficial in the sense that it would reduce the requirement of a trabeculectomy, I think 5 years down the track. But we didn't look specifically at this in our trial.
Thank you.
Thank you.
It's now my pleasure to introduce Dr. Sarah Oh, who will be presenting a randomised control trial, laissez-faire versus direct surgical closure of full thickness lower lid defects. Thank you, Sarah.
All right, good morning. My name is Sarah Oh. I'm an ophthalmology registrar at Tairāwhiti Hospital in New Zealand this year, and also in my second year of doctoral studies at Auckland University and Waikato Hospital in New Zealand. Firstly, I'd like to thank RANZCO for the opportunity to present our preliminary findings from our research, and also like to thank my supervisors, Dr. Stephen Ng and Dr. James McKelvey from Waikato Hospital, and Dr. Jee Ah from the University of Auckland. Well, as you already know, Australia and New Zealand have one of the highest rates of non-melanoma skin cancers in the world. Around 10% of these occur in the periorbital region, most commonly in the lower lid. That's at least 2,300 cases in New Zealand and over 60,000 cases in Australia. And what's more is that the incidence is rising. Well, here is the most common scenario, a BCC in the lower lid. These are surgically excised with 2 to 4 millimeters of normal appearing tissue around the tumour, or by other margin control techniques such as Mohs micrographic surgery. And here's the defect. So what would be the most good way to reconstruct this? Well, direct closure is the most common technique used to reconstruct such defect. It's quick, and the final functional and aesthetic outcomes can be excellent. But if the lid is closed under undue tension, entropion, wound dehiscence, and subsequent corneal injury can occur. Another option is laissez-faire. This is a French term meaning leave it alone, and it utilizes secondary intention healing, the natural wound healing process. The use of laissez-faire in the eyelids have been reported since 1957, mostly in the plastics, ophthalmic, and dermatologic surgical literature. However, these are limited to retrospective reviews or case series with small numbers. Laissez-faire is simple and effective, and the complications are actually similar to that of the direct closure. Yet, it is still underused, and generally as surgeons, we may be inclined towards stitching things up. So, we set out to do a randomised control trial to show that laissez-faire is non-inferior to direct closure in lower lid reconstruction, and perhaps laissez-faire may be better in some situations. Our randomised control trial is based in the Oculoplastic Service at Waikato and Nelson regions of the Te Whatu Ora. After excision of lower lid tumours, patients are assessed. Regardless of the size of the horizontal width of the defect, as long as the defect is full thickness and directly closable, patients are randomly assigned to either laissez-faire or direct closure. Patients are excluded if the defect involves the medial or lateral canthus. And due to the nature of the interventions, blinding is not possible. As for the outcomes, we're looking at anatomical integrity, complications, and importantly, patient satisfaction. So far, we have 35 patients randomised. Both the laissez-faire and direct closure groups had comparable demographic features, with the average age of the patients being 72 and 75. Currently, there's a slightly higher proportion of New Zealand European represented in the laissez-faire group. Over 3/4 of our patients received Mohs excision surgery, and 85% of the lesions have been basal cell carcinomas. Complication rates were also similar in both groups. Most notably observed was the punctate epithelial erosions and trichiasis in the first 3 weeks. In most cases, the punctate epithelial erosions resolved with lubricating eye drops, but this persisted in 2 laissez-faire patients and 4 direct closure patients. There was similar amount of lid retraction, minor lid retraction in both groups. Vertical lid notching was more prevalent in the laissez-faire group. However, the average amount of lid notching was actually less than that of the direct closure group. And these were not cosmetically significant for any of our patients. Wound dehiscence occurred in 3 direct closure patients, which then went on to heal satisfactorily with laissez-faire without any complications, which further strengthens the use of laissez-faire. No patients have required revision surgery, and although these are the findings in the first 35 patients, you can see that the complications are not that different. At the 3-month visit, we asked the patients to self-rate their outcomes and quality of life from a scale of 0 to 10, with 0 being poor and 10 being excellent. The 2 groups had comparable scores with overall satisfaction greater than 9 out of 10. All patients were very satisfied with their final eyelid appearance and scored very highly. For the improvement in patients' quality of life after surgery, there was a trend towards the laissez-faire group. And given this is a preliminary results, it is possible that this difference may become statistically significant later on. These 2 patients were treated with laissez-faire and were very pleased with their results. On the left is a 32-year-old female with a very non-descriptive lesion on her right lower lid. This turned out to be a BCC on biopsy. On the right is an 86-year-old gentleman who had an infiltrating BCC. Both patients underwent Mohs excision surgery and followed by laissez-faire. All of our patients, including the direct closure group, had chloramphenicol ointment for the first 3 days, and the eyes were not padded. At 3 weeks, you can already see that the lower lid margin is formed and granulation is almost complete. By 3 months, the new lid margin is fully formed. Although the trial is still ongoing and these are the preliminary results, there were some surprising comments from our patients that I'd like to share with you today. Our initial expectation was that most patients would favour surgical repair. However, when we were introducing the study, a surprising number of patients across all age groups said leaving the wound to heal by itself would be good if it was possible to do so after removal of their lid lesion. After healing by laissez-faire, some said they were pleased not to have had stitches, and many were actually amazed to have seen the healing process themselves. Some commented how they would like to be treated with laissez-faire again if they had to have another lesion removed around their eyelids. Another interesting observation was that due to wound contracture, the size of the wound, the defect, often becomes measurably smaller just overnight. On the left is a patient who immediately after Mohs excision of the lesion. And on the right is the same patient just next morning when we review the defect for reconstruction. So delaying reconstruction by a day or more may be worth considering, as the size of the defect influences the surgeon's choice of reconstructive method. When the defect becomes spontaneously smaller, laissez-faire can declare itself as a more obvious option. On the other hand, by day 5 to 7, the size of the defect hadn't changed so much compared to day 1. But don't lose your nerve, because eventually they do get better. We noticed that for the larger defects, the most wound healing occurs between the weeks 6 to 10, and all of our patients were fully healed by the 3 months. In summary, this is the first randomised controlled trial comparing laissez-faire and direct closure in reconstructing full thickness, lower lid margin involving defects. So far, our preliminary results show that the final functional outcome, appearance, complications, and patient quality of life and satisfaction scores from the laissez-faire have been comparable to direct closure.
Thank you very much, Sarah. Do you have any questions from the audience?
Tom Campbell, I have a question. Do you have pre-specified non-inferiority margins and a trial endpoint? Because one of the problems is if you do interim analyses, you can have a form of p-hacking where you keep going with the trial until you achieve the statistical result that you want, and then you finish the trial at that point, even though it's just a random variation in the difference between the two groups.
Yes, so there wasn't many literatures out there that specifically looked at full thickness, applying laissez-faire to full thickness lower lid margin defects. There was only two notable studies. And also, because the direct closure is the default option for a lot of the lid reconstruction surgeries, not many people actually investigate looking at complications or success rates for direct closures. So given the limited literature, we did have to base our sample power calculations from our preliminary results, and currently that has given us the total population of 97, so that's 47 participants in each arm. And the non-inferiority, we've defined our primary outcome for the non-inferiority comparison would be mainly looking at the complication-free rates in each of the groups in terms of total rate of complication and the proportion of how many in each group, and comparing that, we've defined it as 10% would be non-inferiority clinically significant margin. And another point was the quality of life, whether there's a difference in proportion of patients who thought the quality of life improved before and after surgery in the two groups.
Hi, Leo Sheck, Auckland.
Yeah.
Interesting study. I just want to ask you, in the laissez-faire group, when the healing occurs, is there a regeneration of the eyelashes and the tarsal plates in the area involved?
So that's another main difference between the direct closure and the laissez-faire. So direct closure would achieve basically the uniform thickness and the equal anterior, middle, and posterior lamellars, depending on the defect size and whether it involves a tarsal plate. However, then the laissez-faire, it doesn't reconstruct in those layers at the lamellars that specifically, so it actually ends up being a bit thinner, and we do have absent tarsal plates. And also the other main key thing would be the absence of eyelashes regrowing. So no eyelashes are regrowing afterwards with the laissez-faire group.
Any more questions in the room? I have a question for you, Sarah. Please, can you describe the surgical technique used for lid closure?
The surgical technique?
Yes.
So surgical technique used for the direct closure would be basically usually a single stitch going through the lid margin, aligning that first with the grey, and then aligning on the skin side would be the grey line suture and so forth, depending on the vertical size of the defect. Yeah.
And how long did that, the one through the grey line, how long did that stay in?
That only stayed in for the first 5 to 7 days. So we often we would see the patients 5 to 7 days following the operation, and that's when we remove the stitches on the skin.
Okay, thank you. We've got lots of questions, so maybe if we can't get through them, then people could talk
yes,
to
please
Sarah,
come and find me at lunchtime.
Sarah afterwards, but there's one quickly. In addition to patient opinion about their healing, did you look at reactions by family and friends?
We didn't specifically ask the patients that. However, when we do see often the patients at 1 week or 5 to 7 days, and then at 3 weeks and at the 3-month mark, obviously there are some comments that the patients share. Well, some obviously said, some family members have also said to us that, wow, can we leave this as it is? A lot of the responses have been, are you sure, can we do this? And then that response kind of stayed with the patients and the families for the first initial visit, the post-op visit, and then often by the 3 weeks, it started to regrow already, so a lot of them have said, oh, it's coming, we're excited to see what it's going to reach to, so.
Fine, thanks very much.
Great, thank you.
Right, so the next paper is by James Wong, and his title is Efficacy of intravitreal pegcetacoplan in geographic atrophy, 24-month results from the phase 3 Derby and Oaks trials. Thank you.
Thank you very much, Claire. I think we all need a degree in linguistics to know how to pronounce some of these new molecules. Good morning, my name is James Wong. I'm a medical specialist from Sydney, and I'd like to present the 24-month data of the phase 3 Oaks and Derby study for the efficacy of intravitreal pegcetacoplan on behalf of my co-investigators. So geographic atrophy is the late stage of dry macular degeneration. It's a progressive disease characterized by loss of photoreceptors, retinal pigment epithelium, and choroid capillaris, which leads to irreversible vision loss. So GA is estimated to affect about 5 million people internationally and over 1 million people in the US. We know that the lesions increase in size by about 1.5 to 2.1 millimeters square per year, and we have no currently approved treatments for GA. Some of the risk factors for GA include exponential risk with increasing age, so a lot of our patients in late 70s and 80s. Genetic and environmental factors are also important. Some of the phenotypic risks include soft, large drusen and reticular pseudodrusen. We know that GA in the fellow eye can also be a risk factor for GA. So this is a fundus autofluorescence scan of one of our patients showing geographic atrophy progression over time. We can see on the left the baseline and 8 years later an increase in the lesion. So fundus autofluorescence is a non-invasive retinal scan looking at fluorophores in the retinal pigment epithelium, and the healthy retina should have a medium grey colour. GA, or formerly what we call C-RORA, or complete retinal pigment epithelium and outer retinal atrophy, produces the black areas which are irreversible. So you can also see the perilesional hyperautofluorescence on the areas here, which often indicate some stress cells there before they lead to atrophy. And this is a phenotypic type of GA which has a high risk of progression. So we can initially see that in the left picture, the fovea is spared, but over time there's progression and loss of central vision. Fundus autofluorescence is one of the gold standards of detecting and monitoring of patients with geographic atrophy. So we've known that the complement system, which is part of our innate immune system, and inflammation is important in the pathogenesis of macular degeneration. Genome-wide associations have shown that mutations in the complement factor H gene is associated with increased risk of MD, and histological studies have shown complement components in drusen and around GA lesions as well. So the overactivation of the complement system seems to be implicated in the pathogenesis of geographic atrophy. Here we can see C3 cleave to form C3a and C3b. We know that C3a causes inflammation, and C3b can also cause cell death through opsonization and a cascade through the C5 membrane attack complex. Pegcetacoplan binds both C3 and C3b, and we can see that it stops inflammation and cell death this way as well. So this is the phase 3 Oaks and Derby studies. This was enrolled 1,258 patients across 232 sites internationally. The patients were randomised in a 2-to-1 intravitreal pegcetacoplan versus sham, and every month or every other month matched as well. Surprisingly, through COVID, actually, we had good retention of patients. So the primary endpoint was at 12 months, and the change in the total area of GA was measured based on autofluorescence. Secondary endpoints were measured at 24 months and not only included the GA lesions measured on anatomical endpoints, but functional endpoints, including BCVA, low luminance BCVA, reading speed, and functional retinal independence, as well as microperimetry. The key inclusion criteria were age over 60 and BCVA more than about 6 or 96 letters. It's important in this study to have the GA lesion requirement from about 2.5 to 17.5 millimeters squared, and GA lesions with or without subfoveal involvement were included. If the lesions were multifocal, then one focal lesion had to be over 1.25 millimeters squared. So the presence of perilesional hypoautofluorescence was also an important inclusion factor in the study. Exclusion criteria included GA second to conditions other than macular degeneration, such as macular dystrophies, including Stargardt. The presence of present or previous choroidal neovascularization in the study eye was also an exclusion. However, the CNV in the fellow eye was not an exclusion. So here are the 24-month results. We can see that pegcetacoplan slowed GA lesion growth in both monthly and every other month dosing. The reduction in GA lesion growth was similar across the Oaks and Derby studies, and the treatment effect increased over time, most notably between the 18-month and 24-month time point. So on the left, we can see the Oaks study, at month 24, 22% reduction in GA lesion growth in the orange with monthly injections, and 18% reduction in the every other month group, and compared to the grey in the sham in grey. On the right, the Derby study, at 12 months there was no statistical significance, but at 18 and 24 months there was, and showing at 24 months a 19% reduction in the per monthly group and the 16% in the every other month group compared to sham. So these graphs show the reduction in GA lesion growth by the lesion location. So we mentioned earlier that lesions both subfoveal and non-subfoveal were included. We know that the non-subfoveal location GA actually increases more rapidly than the subfoveal location, so it's not surprising to see a larger magnitude of benefit in the non-subfoveal group. And despite the slower growing nature of the subfoveal lesions, you can see a still meaningful reduction in lesion growth in the subfoveal lesions. Both monthly and every other month of pegcetacoplan slowed GA progression. So on the left, 24% reduction every month and 22% in the every other month. In the subfoveal group, 19% in the monthly and 16% in the every other month. As a matter of interest, the number of subfoveal lesions were about 35% in the non-subfoveal group and 65% in the subfoveal group. So the 24-month time point was the first time that functional visual endpoints were assessed. The endpoints of BCVA, maximum reading speed, functional reading, and microperimetry. There was no statistical difference between the pegcetacoplan and sham groups in any of these functional arms based on the pre-set requirements. The graph on the left shows the reduction in both sham and pegcetacoplan groups at 24 months by about 7 to 8 letters or so. So this is, we know that the structure and function of GA may be different, and perhaps this may take a longer time to see some benefits in visual function. We also had a heterogeneous GA population, and perhaps the endpoints that were measured may not be the best measures of visual function. So we know that patients with GA have a reduced zone of functionality outside that of which is determined on the autofluorescence scan. And so there was a post hoc analysis of the microperimetry in the perilesional area. This was defined as an area 250 microns on either side of the GA lesion border. And this junctional zone is the area of greater risk to further atrophy. It's thought that the pegcetacoplan may preserve some of the retinal function, particularly in the photoreceptors in these areas, and so it makes more sense to have a look at specifically in these areas. And so there was actually a signal of functional preservation with pegcetacoplan in both microperimetry endpoints. On the left, we have the mean threshold sensitivity. We can see that pegcetacoplan reduced the loss of retinal sensitivity versus sham, mainly from the 18 months to the 24 month. Also on the right, the scotoma number of points there was also reduced in pegcetacoplan versus sham, again from the 18 month to the 24 month arms. P-values are below 0.05 for the every other month, but approaching that for the per monthly arms. So you can see again the separation of the curves on the functional, which is the first time that there's any signal for functional improvement. So in conclusion, we know that pegcetacoplan from these studies slows GA progression with both every month and every other month dosing, with the effects increasing over time. There's no significant differences in the pre-specified functional endpoints. However, there was a signal of functional benefit in the post-hoc analysis of the perilesional areas on microperimetry. We have a Gale extension study which will provide interesting data out to 5 years, and the applications have been made to the US, European, and also the Australian authorities for later this year. Thank you very much for your attention.
Thank you, James. Are there any questions from the audience, please? James, I might ask one. If obviously this is an area of great unmet need and forms the bulk of vision loss from macular degeneration, how are we going to identify patients who are eligible? Obviously, extrafoveal lesions were included in the trial, subfoveal lesions were included in the trial. How are we going to sort of wade through patient selection issues if it gets approved in Australia?
Yes, a very good question. Look, I think it is exciting that if it's the first phase 3 trial showing some positive results of a treatment previously a disease which has not been treatable and is still reversible. I think imaging is going to be really important in the way forward. We know that certain scans, autofluorescence or OCT are really important in diagnosing. It's going to involve a lot more collaboration between optometry and ophthalmology in identifying patients. There's a lot of patients who have GA who do not need injections and will not need it and will not progress. So I think it's identifying not only who has it, but also the progression over time and whether that's going to influence their vision or not. For fundus autofluorescence, it's a very inexpensive imaging, and I think that in the future we'll be having to gear our practices to have a look at that as well. I think identifying patients in the community who may not be seeing us as ophthalmologists, I think would be really important as well. So I think certainly starting to have the conversation about, are there patients who have geographic atrophy who may also have neovascular macular degeneration? I think it's important to be looking at that as well.
Hi, James. It's Leo up here.
Oh, hello.
Yeah, it's from Auckland. Quick question. There is some evidence that drusen and reticular pseudodrusen may be separate diseases. Did you separate out those two groups in your study, and whether there's a difference in response to your molecule based on the presence and absence of reticular pseudodrusen?
Good question. Look, there was no analysis of that in this particular study. I think that's a very interesting question. We know that subretinal drusen or reticular pseudoretina is a high-risk phenotype, and yes, there is some thoughts that maybe it's a different disease to standard drusen, but these sorts of things will be looked at later. I think the main thing was just whatever the GA lesion was produced, from whatever cause, was the main thing that was looked at from an anatomical basis.
We've got one question from the chat. Has any genotyping of the patients been done for these studies?
Not from this study. I know some of the previous studies which were involved in looking at GA treatments were looking at genotyping in terms of risk factors in a complement factor I, but not particularly for this study.
Thank you, James.
Great, thank you very much. Thanks.
It's my pleasure to introduce our last speaker for the session, Dr. Ayub Qasim, who will be speaking on common genetic variants and the prediction of visual field progression in glaucoma, a prospective longitudinal study using a glaucoma polygenic risk score. Thank you.
That's right. Thank you for the intro. So glaucoma is one of the most heritable human diseases. This is a study from a national US insurance database showing that this study examined a third of the US population and ranked the heritability of all common diseases. And glaucoma, as you can see, that ranks the top 3 most heritable disease. We also know from family studies that if you have a positive family member with glaucoma, you're up to 10 times the risk of developing yourself. So this really gives us a unique opportunity to identify high-risk people early so we can prevent this blinding condition. And one method to harness this to our advantage is use this concept called the polygenic risk score. So every person in this room and every patient we see in the clinic have a unique genetic fingerprint. That genetic fingerprint is actually driven by these single base variations in our genome. They're called single nucleotide polymorphisms, or SNPs for short. Genetic association studies really try and associate these SNPs, and we have on average 1 million of them, with diseases. And a polygenic risk score, or PRS for short, is an extension of this idea that we can use the disease-associated SNPs to build their risk predicting profile. So in simple form, a patient can be genotyped, and we identify that they carry 3 strongly glaucoma-associated SNPs. In a simple form, a PRS can simply be the total sum, so it will be a total score of 3. A more sophisticated PRS, like the one we would use, would weight the SNPs that are more strongly associated. They score a lot more higher than the weakly associated ones. We then convert that into a normal distribution by comparing it to other people. And an individual carrying most of the SNPs would then be, say, like in the top 5%, which would be considered pretty high risk. So we built a multi-trait glaucoma PRS that not only encompassed glaucoma diagnosis itself, but also included endophenotypes that are strongly associated with glaucoma. We started by studying the list of SNPs associated with IOP in hundreds of thousands of people from biobanks and genetic consortia. I then personally graded optic disc morphologies of over 35,000 discs, trying to understand how SNPs can influence the disc diameter. My professors, supervisors, Professor Jamie Craig and Alex Hewitt, have then graded another set of vertical cup-to-disc ratios, and combining these, we've come up with a list of SNPs that influence the disc cup, the cup size, adjusting for the disc diameter. Putting all of this together, we came up with a comprehensive score that included 2,673 uncorrelated SNPs in it. So I've talked about this before, and we've published on this. We know that this glaucoma PRS is quite strongly associated with the risk of developing glaucoma, some 15-fold risk. We know it is associated with more treatment, both medically and surgically, and we know it's associated with younger age of diagnosis and more family members affected with higher pressures. My question has been whether we can use this same score to predict glaucomatous visual field progression in a longitudinal design. So for this, I used the prospective study design of individuals followed up for about 5 years. These are individuals who are enrolled in the Progressor study. This is a longitudinal study of individuals who are either glaucoma suspects or very early glaucoma, who have been followed up every 6 months with the visual field testing done at every visit. The main outcome has been associating this glaucoma PRS to a glaucomatous visual field progression. Secondarily, I also looked at rate of RNFL thinning as supportive evidence. So to study visual field progression in a large cohort of longitudinal data is not an easy task, and it's something that I've given a lot of thought about during my studies. I've come up with a scripted pipeline that allowed me to generate reliable and robust data that can change as the study evolved over the course of my studies as well. So this process begins by downloading the visual fields from different clinic sites across, often in a PDF format for compatibility. I then built a customized index that allows me to integrate each visual field file to an individual ID, the correct eye, as well as the date of assessment. Now, this is a very important step because then it allows me to programmatically interact with the visual field data without a user interface, allows me to call it in my next steps. So the longest and more complex step has been to build the customized script in the R programming language that allow me to extract each of the 52 visual field locations from a visual field, as well as the pattern probability map, the reliability indices, and the global visual field indices. This step allows me to generate a simplified spreadsheet of each visual field, having all the required data for further analyses. I then built a statistical modeling that allows me to grade a series of visual fields using a predefined progression algorithm, such as the one implemented in the Progressor study. Now, this series of steps produce incredibly reliable results because it is algorithmic and has been validated against human grading. It allows completely transparent methods. Any scientist can read the code and realize exactly why a series of visual fields progressed and when and in which location. We can reproduce the analyses. Now, this is incredibly important in the era of big data. The studies are ongoing, patients get more fields, so we can always get more results and reproduce the analyses. And finally, we can cross-validate it either in new cohorts or by simply implementing a new progression algorithm, which I've done and I will talk about in a sec. So using this pipeline, I've graded 27,000 visual field series of 1,211 individuals enrolled in the Progressor study. So visual field progression in Progressor is defined as individuals developing a new glaucomatous pattern visual field defect that had to be reproduced in 2 reliable consecutive visual fields. That's the triangles shown on the figure. So I've included all eligible eyes and statistical modeling adjusted for inter-eye correlation, baseline visual field mean deviation, age, and sex. So using the top 5% of the PRS as my bracket for high genetic risk, I've identified 132 individuals who are high genetic risk. You'll see that that actually corresponds to 12% of the Progressor cohort. In some ways, this validates that the PRS indeed captures high-risk people, but also it shows that the Progressor cohort, who are glaucoma suspects or early glaucoma, are enriched with the genetic phenotypes that we're testing for with the PRS. There were about 42% males, and their age of enrollment was 62 years, which was similar between the groups. There were more family members affected in the high genetic risk group, so about 1 in 2 people had a positive family history. And importantly here, treatment was significantly more in the high genetic risk group. I must emphasize that all clinicians involved in the study design have been and currently are masked to the PRS status. So this is in some ways, it's a retrospective analysis of a prospective study design. All right, so results. So visual field progression, I've shown that the high genetic risk group at the top 5% had a significantly greater likelihood of visual field progression during the study course by about 50%. Now, very excitingly, that was evident very early in the study course at the 2-year mark and persisted despite that high group receiving more treatment during the follow-up period. I sought to validate my findings, and one way to do this is use a different criteria set by a different group. So for this, I used the initial glaucoma treatment study criteria, or the CGIT study. The visual field scoring matrix is quite complex, but it essentially grades visual fields based on points per location that is defective on a pattern standard deviation plot. And I've simply generated that and calculated for every series of field using that previously aforementioned code base. And using an identical statistical modeling, I've shown that the high genetic risk group had a 77% greater risk of glaucomatous visual field progression on a CGIT criteria. Secondarily, I also examined the rate of RNFL thinning, showing equally that the high genetic risk group had a faster rate of RNFL thinning, as well as a greater likelihood of progression. In conclusion, glaucoma is a highly heritable disease, and this novel, new, exciting technology allows us to capture individuals who are at high risk and who would potentially benefit from closer monitoring or early observation, or even initial starting that treatment a little bit earlier. This test can be obtained quite readily with either a blood test or even a saliva kit, and my professors and his partners with Sionix Laboratories are translating that in practice within the next 12 months, so that's very exciting. I will also mention that they've got a booth if you wanted to chat to them about it in the exhibition hall. So as exciting as this is, there are some limitations to this work, mainly that genetic studies are still focused on European ancestry individuals, largely from the original genomic data, but multi-ethnic biomes are increasingly being used, and that will be fixed pretty soon. Treatment was not protocolized in our study, and we know treatment affects progression, so it's exciting that we could still see our findings, but that would certainly have affected our results. And finally, our cohort was that of early glaucoma patients, and how that will translate to the general glaucoma cohort is still an area of study. Thank you.
Thank you very much, Ayub. Very interesting study. Any comments, questions from the audience? While we're waiting, I have one for you. Did the participants know about their genetic status at any point?
Yeah, the progressive, no, we did not inform them routinely of the results. At the moment, the results, the actual genetic testing is a research grade study, so it needs to be validated with NAT accreditation before we can actually disclose that as a meaningful clinical result. And that's actually happening pretty soon. Hopefully in the next few months, we'll have that accreditation.
Thank you, because I wonder whether that might bias or change their behavior regarding medication use.
No, we have not informed them as of yet.
Okay, thank you. And do you have any data on intraocular pressure?
Yes, we've published on that previously, but there's about 2 millimeters of higher pressure between the high genetic risk group and the low genetic risk group over the study follow-up period, on average.
Ben, thank you. Thank you. Any questions from the audience?
I might just add to that intraocular pressure results. I guess in some ways the proof is in the pudding as well. There has been such a strong association between the polygenic risk score and the treatment intensity. So we studied that in advanced glaucoma studies, and we find that there is consistently more trabeculectomies and incisional surgeries performed. And in the progressor cohort, there's just been consistently more medications used in this thing. And again, that's masked to all participants and clinicians.
Thank you. There's a question here for clarification. Was the AI algorithm used in the analysis of more than 12,000 visual field files?
What's that, sorry? Whoa.
Was the AI algorithm used in the analysis of the more than 12,000 visual fields?
Was it?
Yes.
No, it was not an AI. It was a simple code of a predefined algorithm. So it's an algorithm that matches a human grading of the visual fields identically.
Okay, and you use that for all
12,000
files, yeah.
Correct.
We looked at each other when we saw the workload. I think the very fact there's few questions is that it was such a very well described study, so thank you.
Thank you.
Well, I'd really like to thank the speakers very much for a very, very interesting series of presentations, very variable, very high quality science, and I'd just like to thank you very much. Thank you, and thank you to the audience.